Our special guest today is Dr. Timothy Aksamit, who is a pulmonologist at the Mayo Clinic in Rochester, Minnesota. He's also the medical director for the Bronchiectasis and NTM Association, and he has been instrumental in the development of our new care center network. Welcome, Dr. Aksamit. Great to have you join us today. We promise to give you the hardest questions we can think of.
Thanks, John, and a special appreciation to you and Katie for the invitation to come and spend time with all of you. It's really my honor and privilege to do that, and I feel as though this is really a special moment that we can spend this time together and to join you on your coffee break, if it will, as you will. It reminds me of those days growing up, coming over to one's house for cup of coffee. And so I hope we can open up our conversation and keep this informal and make this a meaningful experience and give you helpful information about those concerns that are really sometimes very weighty as things go. So thank you again, and very happy to be here with you.
So, Dr. Aksamit, as you know, Katie and I are answering questions and talking to patients every day. And there's a common theme that many patients, especially when they've first been diagnosed and they look things up online, they're paralyzed by the thought of what might happen to us. And so how can we, as a group of patients, weigh the risk of NTM lung disease versus the possibility and severity of the side effects of treatment that we keep hearing about?
That's a great question, John. In my experience, for those of you that maybe we've spent time together in the clinic, and for everyone else, it can be overwhelming. And like so many aspects and so many parts of our lives, that I think that the answer or the secret sauce here to this approach is to spend that time up front to get our homework in. And I use it the pillars of education, in communication, as well as advocacy and empowerment for all of you to learn more about this. And it's not a simple matter of just going through a single paragraph or a page and understanding all that you need to know, but to put that time in, to talk with peers, colleagues, to use venues like this coffee break and others, and the resources that John and Katie will share with you through the Bronchiectasis and NTM Association to help you be informed and move forward. It doesn't mean that there are questions or problems don't exist. It just helps us better adapt to this. And I think that the most education we have about these aspects will inform us and put us in the strongest position to move forward. So, for example, with NTM, patients come across lots of material, some accurate, some maybe not so much, but can be overwhelming. And what I would really reach out and reassure and give you the information about non-tuberculous mycobacteria as well as bronchiectasis, in my opinion, they're manageable. Bronchiectasis is a permanent scarring of the bronchial tubes. So our goal isn't to make it go away, but to prevent it from getting worse. In the case of an NTM infection, it's my personal opinion and practice that I think we should be able to address this to stabilize symptoms and improve situations. Will we cure all infections all the time? And the answer is not necessarily. So when we start thinking about what those options are, at every step of the way, I think it's important to have an open dialogue with your providers, with your physicians. What are the risks? What are the benefits? If I do this, what can I expect? If I don't do this, what can I expect? And oftentimes the perspective that I share with patients is if we leave this unattended and allow this to progress and lead to accelerated loss of lung function, we can't gain that ground back. But if we stabilize the situation, we may be able to go on for long periods of time without necessarily having this all resolved. And that's a little different situation than if I was to see a patient with a run-of-the-mill pneumonia. I would give them a short course of antibiotics of 5 or 10 days and the pneumonia in most instances will go away, and it's nowhere to be found on an X-ray or a CT scan. In the situation of bronchiectasis with or without NTM, non-tuberculous mycobacteria, that's not the case. We are in a position, though, to manage this, and in my opinion, manage it effectively. Every patient is very different on how we respond to our therapeutic plans, so it's hard to say one size fits all, and to say absolutely you can expect this, this, and this, but you won't have any of these other side effects, when in fact the experience is just the opposite. Each person is very different. This oftentimes involves a team concept, in the sense that it's not just about you wrestling with this with just a single provider. Oftentimes there are others. So I work very closely with my infectious disease colleagues in instances, and I tap into the expertise and care and wisdom, if you will, of my other colleagues in respiratory therapy, in pharmacy, in nursing, even in psychiatry or nutrition. Excuse me, those are all aspects that sometimes, but not always, we need to be able to incorporate. So I would first start out and say that through that education and empowerment, spending time together, walking this path together, we can't do this alone. We can effectively manage this and hopefully get you to a spot that really will allow you to stabilize symptoms. And maybe I'll stop there, John, and I'll see if there's any follow-up that may be helpful.
All right, Dr. Aksamit, it's really common for many patients to go to one of the major research hospitals to get our diagnosis and return home to be managed by our local doctors. Often there's a problem with communication between the Center of Excellence and our local doctors. Can you give us some tips on how to improve the communication between the research centers and the local doctors, so they get the information in a timely manner and the patient knows what exactly is going on?
That's a great question, Katie, and I thought you were going to ask me just easy questions, not all the hard ones here.
I think you can handle it.
So this falls into this similar type of a category that not one size fits all. And I think the analogy I use is similar to maybe some of our relationships that we have with family, friends, and in the community, that there's not one effective strategy to communicate across all our relationships in all aspects of our life. And the medical components are no different in this situation. I do come back to this concept of you being part of the answer and the solution rather than the problem. That is to say, to be active, to understand what it is that's going on, to help facilitate and encourage your providers at either the specialized centers to reach out to your local providers, or vice versa, to have your local providers reach out. The electronic medical records has made some inroad there to be able to open up those medical records to share in a more transparent way what the perspectives are, but sometimes it requires us to participate, and as we walk this journey together, to reach out. So there's not a one size or one model that says this is the effective communication that all people should follow, and there are no weaknesses here. But if you, for example, go to a specialized center or you have an interaction, make sure that you're mindful of what your last clinical note is. And sometimes that may even look like taking or printing off a copy of your note and having a copy of your X-ray or CT scan or other medical records to be able to share with the providers. Depending on which systems you are and where you're at, those avenues of communication are not always seamless. And I encourage you to be engaged, to be aware and educated about your care. And at times, especially if you're traveling or outside the normal circumstances, take a copy of your clinical record with you. If you happen to be able to get a copy of your X-ray or CT scan, so if and when you need to see another provider to share this information in the spirit of communication, it can be a very effective and helpful tool to make sure that you get the very best care when you need it. I hope that helps, Katie.
Yes, it does. Thank you very much, Dr. Aksamit.
Oh, absolutely. And you hit on a very important point, and essentially, as I'm hearing it, we need to be our best advocate. You know, we hear that a lot. And candidly, our generation, when we grew up, the doctor was the expert, and we were just supposed to take whatever the doctor said. And what we're learning is we have to be actively involved in our own care. And at times we need to speak up. When we were younger, we would just sit quietly and listen to the doctor, but we need to be actively involved. So thank you for that. And I told you the questions are going to get harder as we go. But so historically, you know, everybody that's on this call, we've all felt very alone with our disease. But now we're starting to hear maybe it's some positive news. We hear about some clinical trials, and we hear about some studies going on. Could you give us some highlights from the research side? What's going on in the background? What do we have to look forward to on the technical side?
Thanks, John, and it's a great question. I would share with the group that I'm very encouraged now, and in fact, more encouraged now than I have been through my career, more than 30 years practicing in the space of bronchiectasis and NTM. In fact, I have colleagues, some have coined the term and used in publications and titles that we're in the new age of bronchiectasis and NTM, just because we're on this precipice of understanding more of the pathophysiology and the biology, and using some of the currently available tools to shed light onto something that we weren't quite so aware of. Let me first start with the bronchiectasis space and just share with you that there have been ongoing clinical trials. Specifically, I would share with you that we understand that exacerbations with bronchiectasis, for those of you that have Pseudomonas, we understand that that's a marker that we really need to address. I would share with you that in the recently published PROMISE studies with an inhaled antibiotic called colistin, that they've been very effective to not only reduce Pseudomonas, but improve the exacerbation rates. Now, whether or not this is going to be sufficient to get past FDA and EMA, that is the European equivalent of the FDA approval, is yet to be determined, but it continues to give us reason to be encouraged that we're able to make progress in this situation. The other part of the other aspects of bronchiectasis that are important aren't only just controlling infection, but those other contributing factors, including inflammation within the airways and structural lung disease in this way, and then mucociliary clearance, or being able to produce sputum. And I just want to spend some time and share with you that with the inflammation component, there are new medicines that are able to tweak our inflammatory response in individuals with bronchiectasis, and that it affects the neutrophil, one of the cells that's imperative in our ability to fight off infection and mitigate some of the inflammatory response, not only in the lungs, but elsewhere in the body. And it's called a neutrophil serine protease, but it's just one of the enzymes in this neutrophil that helps in the inflammation and fighting infection to modulate that, and to then result in improvement in symptoms, improvement in the number of exacerbations, and improvement in other outcomes that we measure for clinical studies. There have been a large study, many of you are very aware, it's under the category of DPP1 inhibitors, or dipeptidyl peptidase, which is this enzyme, but it's in the neutrophil. And one of the studies is the ASPEN study, and that is completed phase 3 studies. The FDA has had an expedited approval process now set up for later this year, and we're hopeful. There are other similar substances entering into phase 3 in other companies called the Airleaf study, which has now been published in phase 2, which is a beginning research component, and beginning into an activity study. And to just step back to say that in this category of tweaking the neutrophils, there are several products of these DPP1 inhibitors that show considerable promise and may in fact undergo approval later this year, but we again are waiting on the regulatory agencies and additional data to come out. So from a bronchiectasis standpoint, not only do we continue to have new options, including inhaled antibiotics for infections, but we now are understanding more about this inflammation and have better tools to tweak this that are completing clinical trials in this way. With respect to the NTM, there's always great interest in developing newer, better, and more effective medicines. For any of you that have been on medicines for NTM and have had that experience of saying, gosh, is there nothing better than this? We all identify with that, and I would share with you, not only are there inhaled antibiotics being developed and looked at to have more broad applications, but other medicines coming down the pipeline. So there's lots of things going on in this space in this new age of bronchiectasis and NTM, which brings me to the encouragement for all of you. You're an inspiration to those of us involved in these studies, that without your participation, without your support, none of this would be possible. So again, you're part of the answer and solution here, not part of the problem. And I'll stop there.
Thank you, Dr. Aksamit. I love hearing the updates on the clinical trials, and I really like the new term, the new age of this space. We have come such a long way in the past decade, and it's a dream coming true. So thank you for sharing the updates. Can you now just share more on the future for bronchiectasis and NTM patients?
So hopefully this is a great position, Katie, that we're at this inflection. There have been other diseases in pulmonary medicine and in other areas of medicine where we've had these inflection points and things have really exploded. And many of us involved in this space have that same sense that we're at that point. So, for example, there are many ongoing investigations and interests to try to identify disease much earlier than it is, to be able to intervene. So rather than wait till we feel really crappy and we have more symptoms and there's more permanent lungs, is to identify where and when and how best to understand about disease earlier so that we can intervene and prevent it and not have these symptoms that many of you experience on a day in, day out basis. There's lots of resources within the US, and including the Bronchiectasis and NTM Association to help us with there's a US Bronchiectasis and NTM research registry at many of the specialized centers, now between 8,000 and 10,000 patients enrolled helping with this. There's a care center network, and I'll let Katie or John perhaps share a little bit about this, understanding that as we move this ball forward, there's a lot of interest in identifying disease earlier so that we can prevent that from really getting to the point it is. And then lastly, within the Bronchiectasis and NTM Association, at the global level, there's a World Bronchiectasis Day on the 1st of July that's now celebrated across the globe with more than 25 global partners, essentially on every continent. And as we move forward, it's just not here in our backyards in the US, which we're intensely involved in, but the global community is coming together and trying to walk this journey together as well. I hope that helps, Katie.
Yes, thank you very much.
So, Dr. Aksamit, thank you so much for answering these questions.